Yeah, I absolutely agree with that, and I think that's um, it's an issue. And it's the first time I've really seen it in, because for having spent 25 years essentially working in NHS services, but obviously those NHS services have to treat private patients because of the poor eligibility criteria that are available. But I think the attitude that private providers take to treating patients is fundamentally different. You know, if you go through to a private IVF clinic, you know, they make money from treating you. It's to their advantage to A, investigate, but then B, as quickly as possible, get on and treat. And if you're not having to worry about NHS criteria, and as long as it's clinically reasonably safe to treat that lady, then why would you mess around? And if there's a simpler treatment, for example, insemination, are you going to offer that when actually IVF statistically clearly does better, but also IVF clearly statistically is where the money is? And you know, that's a challenge, and I think it's, you know, it's an area where there is a clear difference, not just in repro med, but as a GP, you're you know, you develop an awareness over the years of clinicians in the private sector who you respect, do the right thing from a clinical perspective, because it's always very easy to do more than is necessarily the right thing. Very difficult to sort of shoot down in flames, as you know, like I was saying, for endometriosis, if you see someone privately who's got some pelvic pain, it's very easy to say, well, you definitely need a laparoscopy. So, you know, that's the flip side. You know, you can make a lot of money, you know, doing procedures that you're very skilled at and become very good at. You know, the whole drama in the United States where you have cardiologists who spend all day stenting people and sometimes put 6 stents in the same patient, you know, at $15,000 a go. Why wouldn't you? And, you know, the other half of their cardiology societies are basically saying that's completely unethical. You know, those patients are much better treated with medical treatment, losing weight, looking at their risk factors, maximizing their lipid profile. You know, and you get the same thing in infertility. You know, there are some very wealthy people who work in infertility, and it's very challenging for the regulatory authorities, the HFEA in the UK, to really control what's done on a treatment level, and to make sure, as you say, that some of those simpler things are done, and you don't, for example, push straight through to saying, well, I think at the end of the day, let's just do a cycle, you know, of high dose IVF, and we'll do ICSI as well because it's a bit borderline. So we'll do the, you know, very difficult to regulate against that. And the patients aren't going to disagree. And to some degree, patients often are very happy to be pushed up the technology ladder. You know, some patients aren't. And I think, you know, there are some patients who come through who want to be, you know, considered in a more holistic way. And if there are options which allow simpler treatment, they want to pursue those. But there's a very big cohort who actually the only question they want the answer to is, what's the treatment that's most likely to get me pregnant? Well, the answer to that is always IVF. So actually, if that's the question you ask, nobody's leading anyone astray. They're actually answering the question honestly, but they're not really looking at it in the broader context, are they? So it's a very tricky area. And I try, you know, we see a lot of ladies who are in their mid-40s. I have to say, I'm always brutally honest with them. I cannot countenance saying to these ladies that, you know, whatever protocol we use or whatever, that, you know, that they've got a high chance of getting pregnant. They absolutely haven't. And I will tell them to go away and look at the national data on getting pregnant when you're 45 using your own eggs, and it's disastrously poor. And even if we get you pregnant, it's extremely likely with a genetically untested embryo that you will miscarry. And they have to understand that before they embark on the pathway. So, but I'm not sure everyone else, or I'm not sure a lot of people necessarily. And again, if their livelihood depends on it, how much do you need to say? So I think there are lots of really complex ethical areas there where, you know, the ethics and the morals of what you're doing potentially conflict with the business model. And, you know, one of my very good friends now works for the HFEA in London, having worked for many years within the clinical IVF world, and I think she finds it very challenging, you know, to try and keep clinical practice aligned with, you know, the right thing to do. Very, very challenging, because, you know, business is business at the end of the day, isn't it? And, you know, for lots of people, it's, you know, and in a private clinic, you know, you pay your staff by the revenue you generate, and your profits accordingly are about the patients you treat, etc. So the NHS is, if you work in the NHS, it's different. You get paid your salary every month, whether you're treating, you know, 100 patients or 50 patients or 70 patients. You know, so maybe you're cocooned to some degree from those realities of you know, the private healthcare world, and so, you know, it's challenging. It's very challenging. But yeah, I think from a personal point of view, I think if I felt that I wasn't able to be honest with patients, then that's the point I'd be wrapping it up, because I think when it becomes driven by money, you then end up compromising your decision making, really, and that's never been the way I've wanted to practice. So